welcome to this program, PHA program. Our topic today is challenges in liver resection, management of pancreatic cancer, case scenarios in pancreatitis. And as you know that Dr. Satya Bhattacharya, one of my colleagues, has joined in, and he'll be the main presenter. And before going to introduce him, I definitely need to tell all of the panelists who are joining in as well today. They are Professor Dr. Mohammad Mohsin Chowdhury and Professor Dr. Bidhan Chandra Das, Professor Dr. M. Majid, and Professor Dr. Khandekar A.K. Azad. I'll introduce Dr. Satya Bhattacharya, and after that, I'll ask Hassan Shahriar Kollon to introduce our Bangladeshi counterparts as well. So to talk about Satya, not only a good friend, but he has got a massive, big biodata, I would say. It would be impossible to say everything in one go, but just to summarize, Bhattacharya is a highly respected and award-winning consultant surgeon based in London, who specializes in gallbladder surgery, pancreatic surgery, pancreatitis, alongside liver surgery, liver cancer, and pancreatic cancer. He privately practices at the London Clinic. I got it all from website. And his NHS base is actually Barts Hospital, where I've been working as well, and Royal London. Mr. Bhattacharya originally trained in Mumbai, qualifying as a doctor from the Grant Medical College. He went on to train in specialist surgery of the liver, pancreas, and bile duct at Royal Free University Hospital, London, and was visiting fellow at the University of Minnesota with a grant received from the King's Fund. Also currently working at the number of prestigious hospitals, including the Royal London and St. Bartholomew's Hospital and the King's Edward VII Hospital. Mr. Bhattacharya has raised large sum of money for pancreatic research. This has helped to run several research projects at Barts Health NHS Trust. He has published over 50 scientific papers, authored numerous book chapters, and is a member of prestigious boards and societies in his field. This includes the International Hepatopancreatic Biliary Association and the British Association for the Study.
Zach, enough. I think enough about me. I'm a HPV surgeon, and that's all they need to know.
Yes, I know that. But the best thing is, he's one of the Queen surgeons as well. That's a big achievement for somebody like him to get the CDO, which is the commander of the Victorian Order of the Kings 2023, but on the list. So he's one of the really renowned surgeons, hepatobiliary surgeons, definitely no doubt about it. And I'm really grateful for your presence in this PHA. PHA is a planetary health academia. The main purpose of PHA is to get all these Bangladeshi doctors from abroad, America, Europe, Australia, and everywhere, and to communicate with Bangladeshi doctors so that we can build up a fantastic atmosphere and learning from each other. Now, Dr. Shahriar Kollon, if you can introduce our Bangladeshi counterpart, please. Kollon?
Yeah. Thank you very much. Do you hear me?
Yes, we can.
Okay. So I'm going to introduce the learned panelist of today's discussion or talk. We have with us one of the most veteran surgeons of our country, Professor M. Majid. He's a consultant general surgeon, now currently working in United Hospital. He is my teacher as well as teacher of some of the faculties as well, possibly. And we have with us Professor Dr. Mohsin Chowdhury. He is the chairman and professor of the Department of Hepatobiliary and Pancreatic Surgery from Bangladesh Sheikh Mujib Medical University. We have with us Professor Dr. Bidhan Chandra Das. He is a professor of Hepatobiliary, Pancreatic, and Liver Transplantation Department, Bangladesh Sheikh Mujib Medical University. And we have with us Professor Dr. Khandekar A.K. Azad. He is the former professor and head of surgery, Chittagong Medical College, Bangladesh. Welcome to the program. Thank you.
Thank you very much for introducing our guest. So I'll not delay anymore. Satya, you can start. The floor is yours now.
So I thought we would have about 25 minutes each on liver resection for tumors, pancreatic resection for cancer, and then acute pancreatitis. Because these are the three main challenges that we HPB surgeons face. I mean, there are other things we do, but these are some of the difficult areas of work. And I would like to do this more as a form of a Q&A where we have, how many trainee colleagues have we got on this session?
I mean, it will be, I'm expecting more than 60, 70, but just 26 have joined now altogether.
So if you have got 20 plus surgeons who are trainees, I would welcome them to pipe up and answer questions and run this partly as a question answer session and discussion session rather than me talking at everybody. I hope that's okay.
So it should be interactive, more interactive program, correct? Yeah.
Please interact and please interrupt as we go. So the
Do you
first.
want to share your screen at all? Do you want to share your screen, Satya?
Yeah.
Yeah. Okay. You can share. Thomas,
Sorry.
please help to get.
Sorry, I did not hear that.
But do you want to share your screen?
Yes. So that's what I'm about to do. Let me just see if I'm able to share my screen now. Zoom meeting, share screen. Are you able to see this?
I will be able to help you. Yes, yeah. Yep.
Are you seeing this?
You can. Yeah.
Is the picture showing up of the liver resection?
Absolutely.
Segmental anatomy? So
yes.
I think this is the starting point for all discussions on hepatic resection, because it is the segmental anatomy of the liver that underpins how we go about resecting. And if you're not familiar with this, then you have to familiarize yourself with it before you start thinking about resecting liver. So we go beyond the right and left lobe concept and divide the left lobe into 4 segments, of which the old caudate lobe is segment 1 and the old quadrate lobe is segment 4. And then you've got 2 and 3 as well, which is the left lateral segment. And then on the right-hand side, you have got segments 5, 6, 7, 8. And anyone can tell me who was the French surgeon or anatomist who first described these segments? Any of the registrars willing to hazard a guess?
His son is Mr. Quino.
Correct. So Claude Quino, who was a surgeon and anatomist from Paris, he described these. And I don't know how far this is true, but they say that it reflects the postal map of central Paris, where there are 8 postal districts or arrondissements, as they say in French. And these 8, if you look at the postal map, it runs in the same way from 1 to 8. I don't know how true that is. But anyway, these segments, if you need to familiarize yourself with them. The next thing I would say is, well, we all know this, but just as a recap, we might be resecting liver for all of these reasons. There might be benign adenomas, which have a potential for cancer, focal nodular hyperplasia, occasionally giant hemangiomas, and then, of course, malignant tumors like HCC, colorectal and non-colorectal mets, cholangiocarcinoma, and in some instances for cysts, especially hydatid. Any takers for what this lesion might be in the caudate lobe? There is a characteristic feature to it, which is why I'm asking the question.
FNH.
Yes, because it has got a central scar. So this is a caudate lobe FNH, which normally you would leave FNHs alone because they do not have any malignant potential. But this was actually a young Bangladeshi woman. And as you can see, her cava was hugely compromised by this FNH. So we ended up resecting the caudate lobe and took it out. Moving on to HCC. Now, as you know, with HCC, the first question is, has it arisen in a cirrhotic liver or a non-cirrhotic liver? And a lot of the next steps will depend on what is the Child-Pugh stage of the liver function. And you would be looking at resection only in small lesions within a normal liver. If there are more than one lesion scattered around the liver, you might be looking at transplantation. You may be looking at ablative therapies. While if it is larger tumors in people with more advanced liver disease, then you're looking at chemoembolization or systemic therapies. Now, resection for HCC, you might say, well, we'll come to the perioperative risks, but looking at resection for HCC, you should be able to get 5-year survivals of 50% plus. We will come to liver metastases in a little while. So when we are trying to resect the liver, our aims are to take out all visible disease, do it safely, get clear resection margins, and leave adequate volume of liver tissue. So if you are preparing for a liver resection, say, what are the things you will want to know beforehand? What are the things you will do? Any suggestions? You've got a patient in front of you. You're thinking of this man will need a right hepatectomy, for example. What is your checklist going to be? What are the things you will think about?
Somebody should say in the training.
Louder.
Rahan.
Sorry, come again. Say that again.
Any one of our student, please.
These are the things I'm thinking of. So first and foremost, when I see the patient, I counsel them. I have information leaflets which I give them to read. I explain to them in detail what is going to be done to them. The second question is logistics. When are you going to do it? Where is the patient's relative going to stay? All of those are usually done by practice managers, but those are the things you have to think about. The third is the patient's fitness. Now, I've put their CPET, which is cardiopulmonary exercise testing, which is not necessary in every patient, but certainly you will want to make sure that they have sufficient exercise tolerance to be able to withstand a major hepatectomy. The function of the rest of the liver that you're going to leave behind, is it normal? Is it suboptimal? Is something you have to think about. And some people will routinely do an indocyanin green clearance test as part of their pre-op workup. I don't normally do that in every instance, but that is perhaps my institutional bias. Other institutions do that routinely. The next thing is you will review the scans and you will do it through a multidisciplinary team meeting. We have moved away completely in the UK from doing, one surgeon or one clinician making the decision that this patient is going to have surgery. You will always have a multidisciplinary team discussion where there will be hepatologists, HPB surgeons, oncologists, gastroenterologists, and radiologists all present. And then there is the question of surgical planning. Exactly how will you resect? How much of liver will you remove? Which segments are coming out? Are the scans up to date? Because we are a referral hospital, often patients come to us from elsewhere. We have to make sure that the scans are up to date, repeat the scans if necessary. Of course, you have to check the preoperative state of the patient, check the clotting, do they need vitamin K? How many units of blood are you going to cross-match? If there is a question of biliary decompression, then that should be done beforehand. For example, for a cholangiocarcinoma, which is, let's say, a hilar cholangio, and you're going to do an extended right or an extended left, the lobe that you're going to leave behind, you want that already decompressed and working properly before you proceed to surgery. So you might have to do a percutaneous biliary drainage beforehand. Finally, HDU or ITU bed, that needs to be booked. And cirrhotics require particular counseling about the risks because the risks are higher. The next thing is on the day or just before the day, you have to prepare to and talk to your scrub nurse. So what retractor are you going to use? I tend to use an OmniTract. Others will use a Graze. Some people use a Thompson's retractor, which is like a goalpost, which sits on top of the chest, and retractor blades pull up the upper part of the incision. So different organizations, different surgeons use different types of retractors, but you need to have a self-retaining retractor, which you will use. Intraoperative ultrasound is an essential part of the operation. And if you're not familiar with this, you should familiarize yourself with intraoperative ultrasound techniques and interpretation before you start doing hepatectomies. If you're going to do any intraoperative ablation or RFA, then make sure that machine is in theater and probes and pads are all there. You must have vascular clamps at hand. Make sure that sister has got all the Satinsky clamps and vascular clamps at hand. You have to think about how are you going to transect the liver parenchyma. Do you use CUSA? Do you use Aquamantis, which is a radiofrequency energy tool? Some people use water jet dissection. So there are different techniques of transection. And you must make sure that your whatever instrument you use is available and ready. Finally, if you're going to do biliary reconstruction, what suture material will you need? Might you need any intraoperative X-rays? What drains will you use? All of these things you have to think beforehand and prepare. What incision will you use? All of these are possible incisions. An inverted T, a Mercedes-Benz, an L-shaped incision, or a long subcostal. This, for example, is a Graze retractor, which you can see is like an arch. And here is one of my team doing an intraoperative ultrasound. Here is a list of all the possible dissection techniques. As you know, in the older days, it used to be finger fracture and Kelly clamps. Then we got CUSA. When I was a trainee in the late 80s, early 90s, CUSA was then new. Everyone was using the CUSA. Nowadays, we have moved on to using some other things, and the CUSA sits at the corner of my theater and looks very angrily at me. It sulks at me, I think. What else? You have to be very aware of anatomical variations. And you can, that's where intraoperative ultrasound comes in very handy. And you have to go back to the CT or MR images. So you should have a screen up in theater where you can go back and see those images if necessary. Here is us using Aquamantis, which is heat coagulation of the substance and then gently cutting through the tissue. As you can see, it's looking quite dry. The liver margins are quite dry. There's not much blood loss happening there. Here is a little more of the same. Which patient is more likely to bleed, do you think, in a hepatectomy? Any thoughts?
Those with cirrhosis and portal hypertension.
Sure, if there is cirrhosis and portal hypertension, they will bleed. Secondly, if there is a underlying deranged liver function or coagulopathy, they may bleed. Certainly, those who are having major resections of more than 3 segments, they are more likely to bleed. And finally, if there is a central tumor, that may bleed more than a peripheral tumor. So the things you can do are, one is pedicle clamping. You can do a Pringle maneuver, and there are risks to Pringle maneuver, but you can do at least 15 minutes inflow occlusion, then release for 5 minutes, another 15 minutes, release for 5 minutes, and a third clamping of 15 minutes maximum. So not more than 45 minutes of clamping, but releasing after every 15 minutes to allow reperfusion. Is certainly a feasible option. This low CVP is interesting because, say, in the 80s and 90s, when hepatectomy became more and more common, the anesthetist would always anticipate blood loss and start almost preloading the patient when the abdomen was opened and the surgeon was beginning to handle the liver. The anesthetist would think, now I'm going to get blood loss, so let me fill the patient up a bit. But actually, the more, especially if you've done a Pringle, then all the bleeding is from the hepatic veins. And if your CVP is already high, then the hepatic venous bleeding is more. So actually, a low CVP is what helps. So underfilling the patient at the time of the hepatic transection is actually the more sensible thing to do. You can do total vascular occlusion in some instances, but that is more technically challenging. Anesthesia for liver resections is, when surgeons discuss surgical technique, we are always talking about what we are going to do. But I think the anesthesia is the crucial part of the surgery, which is driving the mortality down. And most of my patients will have an epidural catheter. They will always have a wide bore central venous access. We will have a rapid infuser available at hand. They all have intensive monitoring. We will try and avoid transfusing and use a cell saver if possible. There are various pharmacological manipulations the anesthetist can do, and we have already talked about low CVP. Finally, most of the patients return to high dependency, already awake, not intubated and ventilated to ITU. This is how my anesthetist end of the table looks. It's all very busy and there's lots of things happening. And in fact, sometimes I find she has a busier time than I do, perhaps. The reasons why surgical mortality is falling is, I think, a multitude of reasons. One is we have a better understanding of anatomy and the physiology. We have better tools. We have talked about the various transection techniques, safer anesthesia, improved post-op analgesia, critical care facilities. We have sort of touched on all of these. But the other big factor is that surgery is being done in high volume units. And this, I think, has made a huge difference in improving surgical outcomes all across the Western world. Not only does the surgeon who operates in high volumes get better outcomes, but also the entire team is more practiced at doing these resections. So that's a very brief run through hepatic resections. I've sort of tried to focus on the practical aspects of how you go about doing these operations. Are there any burning questions that anybody wants to ask?
So I am Dr. Vidhan, working as a professor of hepatobiliary surgery in Bangabandhu Medical University.
Mm-hmm.
Thank you, Dr. Satyajit, for your nice an elaborating discussion. So one question to you, you said you use epidural in all cases of liver resection. So if the patient has cirrhosis background, you use the epidural in cirrhotic background liver.
If we have corrected the coagulopathy, we can use the epidural. If they have an underlying coagulopathy, we will not, because then we'll worry about epidural hematomas. So only if we are happy that the INR is normal, we will do, only in those cases we will do an epidural. Some people are moving away from epidurals because they have their own challenges, as you, I'm sure, will be familiar with. There are issues with hypotension to an extent. There are issues with not always getting the satisfactory block, and the patient moves, the catheter moves slightly, suddenly the block disappears. So some people have started using other options like PCA, patient-controlled analgesia, where the patient presses a button and gives himself or herself a shot of opiate whenever they're in pain, intravenously. And there is a built-in cutoff for how much they can give themselves. So PCA is popular with some people use intercostal blocks. So there are lots of variations, but if possible, we will still use an epidural in most instances.
Okay, so one more question. So you said in hilar cholangiocarcinoma, you always biliary decompression is required before doing any major resections. So what you do if do you practice the PTVE and portal vein embolization before doing hepatic resection in hilar cholangiocarcinoma? I mean, you do the decompression, you do an portal vein embolization, you do regularly, or?
So the interesting problem is, so two things. I think, first of all, biliary decompression is important in hepatic surgery. We will talk in a little while about pancreatic surgery, where some people will not bother with biliary decompression. As long as the bilirubin is below 300, they will say, let's just go on and do a Whipple, doesn't matter. But when you're doing a hepatic resection, I think it is important to achieve biliary decompression beforehand. So PTBD or ERCP guided stenting, whichever is feasible, to decompress the...
Has it top for a pet?
Sorry, I'm not sure what that was, but so it's important to get biliary decompression. Now, the second issue is the volume of the functional liver remnant, or FLR volume. That the easy way of calculating that is it should be 0.5% of the body mass. So if someone is 100 kilos, they need 500 mils of liver as an approximate thing. So if someone has got a body mass of 60 kilos, they need 300 mils of liver, normal liver volume. So all our patients who are going to have complex resections, we will ask our radiologists to use a software that they can use on the CT or MR images to calculate the volume of the residual liver. Now, if we think there is not going to be sufficient volume, there are a few strategies you can adopt. One is you can do a staged resection. So I'm putting these up as we are going. So one is a staged resection. You take away 3 segments of the right lobe, then later on you go and remove 2 segments of the left lobe, but allowing 6 to 8 weeks between procedures for the liver to grow back. The second is portal vein embolization. So where you think that the anticipated liver volume is less than 25% of the total, then you can block the portal vein in the segment that you're going to remove. Then segments that you're going to remove. So then the remnant liver, which will remain, starts to grow. Allow 3 to 4 weeks, repeat a CT, see that the remnant liver has grown, and then you go ahead and resect. We don't have a specific embolic material that I would recommend, but we use things like glue, cyanoacrylate glue, thrombin, coils, all have been used. And mortality of resection after morbidity is about less than 15%. Mortality rate is about 6 to 7% in cirrhotics and 0 to 6% without cirrhosis after portal vein embolization. The other option is ALPS, which, as you know, is a 2-stage resection. I generally do not do ALPS, but it is like transecting the liver, closing, but not disconnecting any of the segments or lobes. And then you wait, and then you go back and actually remove what you're going to remove. So that's the strategies when you think you do not have enough volume. Does that?
Hi,
Yeah.
Dr.
Yeah.
Bhattacharya. My name is Ashraf Malik. I'm one of the transplant hepatologists in USA. I do, we have a transplant program, and the reason I'm interested in today's program, of course, I want to hear the UK perspective of liver resection. That's one reason, and the second reason I really like to pay my salam and my gratitude, Dr. Professor Majid, who is my direct teacher. Majid sir, assalamu alaikum.
Walaikum assalam. Walaikum assalam. Thank you.
So I want to make some comment from Bangladeshi perspective. This is more like a medical point of view. I think this is, like you well said, about prior to doing liver resection, the multidisciplinary approach is what we, everywhere we do. The two things I want to point out, one thing you already mentioned about checking the remnant liver volume, which is important prior to resection. And the second is, I know this is something that came out from all study about cirrhotic patient checking portal hypertension, with the clinical portal hypertension, which is, we always check for HBPG less than 10 millimeter marker with a normal bilirubin. So every patient who does not fit the criteria, it's better to consider for other options rather than liver resection. So since from biology perspective, a lot of our patient has undiagnosed fatty liver disease. They may already have advanced fibrosis. So they should have like a complete liver evaluation, which include not only, the routine labs and everything, but they should have either, I know it's very readily available in Bangladesh, doing a FibroScan called liver stiffness. And there are various studies showing that stiffness of 14 or above, is considered high risk for having patient cirrhosis. So those patients should get some more studies to check for portal hypertension prior to going for a resection, because we see a lot of patients, even with not having cirrhosis, have HCC. So they should get some more workup, prior to going for resection. I'm sure in the UK, this is being routinely done, or at least having transjugular portal pressure measurement prior to going for resection, making sure they don't have clinically significant portal hypertension. So from Bangladeshi perspective, because it's fatty liver disease is so common, not only in Bangladesh, but everywhere else, but from Bangladeshi perspective, resection is commonly done. I think every patient should get evaluated, a full liver evaluation prior to getting resection, making sure they don't have underlying cirrhosis. They may have a low platelet, they may have a slight hypoalbuminemia, and they should get further studies, either getting FibroScan, or if the FibroScan shows high stiffness, they should get further workup with either transjugular liver biopsy to check for portal pressure, or they can even get an endoscopy if they have already varices. We know they have clinically significant portal hypertension.
Absolutely. Totally agree with all the points you've made, and thank you for coming in and saying that. I think we have set aside probably 25 minutes for each of the topics. So it's getting to the point where we should probably move on from liver resections to pancreas. I have one last question for the trainees. Can you all tell me whose statue that is on the picture? Which mythical creature are we showing there? It's very
Yeah, it's Prometheus.
very good. Thank you. So that's Prometheus, and he's been chained to the rock because he gave away the secret of fire to humans, from the gods. So the gods punished him by tying him up, and every day an eagle came and pecked at his liver. So there you see the eagle pecking at his liver. But the fact that he was surviving obviously means that the Greeks knew about liver regeneration. So with Prometheus, let's move on to something else. So pancreatic cancer. Let me just, am I still sharing the screen? Are you able to see? Or no, hang on. Are you able to see this?
Now we can see, yes.
Yeah. Okay. So as most of you will be aware, pancreatic cancer is not a good cancer to get. If you look at the various cancers which are listed here, this is taken from Cancer Research UK, and you're looking at 10-year relative survival in adults. And look at testicular cancer, for example. The survival curve is steadily improving. And yet, see prostate, for example, that's prostate, and see how the survival curve is going up. And for all cancers, again, it's an upward curve. But right at the bottom is pancreas, where the curve is almost flat. So that is the problem we have with pancreatic cancer. Now, I'm not going to go into the whole epidemiology of pancreatic cancer because this is not the sort of forum to do that. But as you can see from this slide, these are all studies from the end of the previous century, but things haven't improved hugely across the world even now. So patients are diagnosed late and the resectability rates are quite low. Now, I have a scan here. Would any of the trainees want to talk us through the scan? What are you seeing on this? What is this?
Distended gallbladder.
Very good, distended gallbladder. And here is the pancreatic head. What is this?
Yes, yes, thank you.
Thrombus
Sorry?
in the portal vein.
Thrombus in the portal vein. Excellent. And what are these two structures you're seeing?
Below one is the pancreatic duct and above one probably the CBD.
It's a
Dilated CVD. Perfect. So,
Yes.
so this is already someone who's got fairly advanced cancer. Here is another one. Anybody want to, well, I think that I've given away the answer there on the top, isn't it? But so here is the SMA, and here you can see a tongue of tissue is going out towards the SMA. So is this resectable or unresectable? What would you do if this was seen in your MDT?
This is potentially resectable.
So contraindications to surgery include liver metastases, peritoneal metastases, distant lymph node metastases, major venous encasement, which this patient doesn't have, but arterial involvement at present is deemed a criterion for unresectable disease.
Sir, we can try with the neoadjuvant and then go for the
correct. So very good. So if you were giving neoadjuvant, what would you give? Any thoughts? What chemo regimen would your oncologist give?
If the patient if the patient's performance status is good, I will prefer the
I don't know if you got cut off. I think you were saying FOLFIRINOX. Can you hear me? Hello?
hello. Yes.
Hello. I don't know what happened. Suddenly I seem to lose sound for a little while. FOLFIRINOX, yes.
Yes.
Here is another one. Here you can see that the tumor is abutting the SMV. This is the tumor. The hypodense patch in the pancreatic head is the tumor, and it is you've lost the fat plane around the SMV for about 1/4 of the circumference. So that is abutting SMV, but that we would say is borderline resectable. So one of the challenges which we have is the jaundiced patient. And the question arises of, should all of them have prior biliary decompression? Any thoughts about that? Should everybody be decompressed, or do you have a particular cutoff for bilirubin needs to be over 100, over 200, over 300?
No. In this situation, if I prefer the neoadjuvant therapy, I have to decompress the biliary tree with metallic stent.
So,
which guideline recommends?
If a patient has got operable disease, the question I'm asking is, will you always do biliary decompression? Do you always want a biliary stent in place, or would you say this is operable, let me operate next week? I don't want ERCP and stenting.
There are 3 indications of biliary decompressions actually. Number 1 is cholangitis.
Yes.
Number 2 is intense itching.
Yes.
And number 3 is if it takes around a couple of weeks to do surgery, it's being late. These are the 3 most common indications when we prefer the biliary decompression actually.
Right. So I agree with the points you've made. And if I find that I'm able to operate on this patient quickly, the patient is fit, I can do it within next 1 or 2 weeks, bilirubin is below 250, there is no cholangitis, then I will not send for ERCP and stenting. There is a slightly higher risk of infective complications after ERCP and stenting. The other thing I would say is avoid naked metal stents if resectability has not been assessed at MDT, or you're not sure it is cancer. Covered metal stents are perfectly fine. What do you think is happening here? What scan do you think you're seeing? And what procedure is being carried out?
This is done endonominal ultrasonogram. US-guided biopsy.
Yeah, so you're basically, this is US-guided biopsy of the pancreatic tumor. And more and more we are resorting to this to get prior diagnosis. If the patient has had an ERCP and brushings have given us the answer, fine. Otherwise, we will often do an EUS-guided biopsy to get the histology. Just for entertainment, here is Dr. Codivilla, who performed the first pancreaticoduodenectomy in 1898. Here is Halsted in Johns Hopkins in 1905, and he reported an ampulectomy in 1898, 5 days after Codivilla's operation. This is Walter Kausch. He reported two-stage resections for ampullary carcinoma. This is him with his wife and son. And the Germans always refer to it as a Kausch-Whipple operation rather than just a Whipple operation, because they say that Kausch reported it before Whipple did. And Whipple, whose picture you're seeing there, he published a series in 1934, and he used to do his pancreatic duodenectomies in two stages. Here is a picture of what happens. So once the resection is complete, you've got the pancreatic cut section there. There is the pancreatic duct. Here is the superior mesenteric vein. There's joining the portal vein, and here is joining the splenic vein, and here is the portal vein going towards the liver. So the liver is there. There's a retractor on the liver there. Here is the CBD, cut end of the CBD. Here is the gastroduodenal artery, which has been tied off. There's the common hepatic artery. So that's how the operative field looks once the specimen is out. And there are various ways of reconstructing. This is one way of doing it, which is my usual preferred way of doing it. And as you can see, it is a PPPD, so pylorus preserving pancreatic duodenectomy, which is what I often do now, unless there is a very clear reason for removing the pylorus. There are others who will prefer to put the pancreas on a separate loop and the bile duct and the stomach on one loop. The advantage, they say, is that if there is a pancreatic leak, then it is exposure to food and gut content that activates the pancreatic juices. So if you get a leak from here, the caustic fallout will be less. This is the hypothesis behind it. No one has shown any very clear advantage from it, but some people do this quite routinely. So standard versus pylorus preserving. When pylorus preserving first started, people started saying, oh, that will cause delayed gastric emptying, you might get poor clearance. But actually, we have seen that there is no significant difference in outcomes with PPPD. In terms of quality of life also, there's no difference. So PPPD is now the standard in most places. Is there any benefit in extended lymphadenectomy? The answer is no. What about portal vein resection? If you're going to get an R0 resection by resecting a patch of portal vein or segment of portal vein or SMV, then yes, it is justified. The biggest series show that perioperative mortality and morbidity are similar to standard resection. But I've always found that whenever I've resected portal vein, there are the post-operative recovery is a bit more complicated. They take a bit longer to get over it. That's in my hands. Most pancreatic duodenectomies in our unit last 4 to 5 hours. Usually there is no transfusion. They get extubated post-op, high dependency rather than intensive care. Epidural, median inpatient stay is 14 days. And 0 to 4% 30-day mortality in most high volume centers. There is a very clear, just like we were seeing in the hepatic resections, there is a very clear relationship with surgery being done in high volume units. There is another thing here, which is the somatostatin analogs. Any thoughts about that? Do the surgeons in this group use octreotide perioperatively or not?
So evidence telling that there is no benefit of giving octreotide perioperatively.
So
I would disagree with that. I think the evidence for somatostatin analogs is very interesting. It loses its efficacy when it crosses the Atlantic.
Yes.
All the
Yes.
European studies show some benefit. All the American studies show no benefit. The
Yes.
Americans criticize the Europeans saying, all those are sponsored by pharma companies, so you're seeing a benefit there. Nobody knows where the actual truth lies. But my logic is, of course, there is a cost issue, and I'm working in the National Health Service where the patient is not paying for it. And the NHS is willing to pay for octreotide. But if cost is not an issue, then there are very few side effects from giving octreotide. So, and pancreatic leak is such a horrible complication that I think anything you can do to prevent it is worth doing. So I give octreotide to all my patients perioperatively. But I'm willing to accept that the evidence is dubious and some people might not want to give it. Here is a study which you all must be familiar with, which showed how in, say, colectomy or gastrectomy, there isn't a huge difference in terms with volume in outcomes. But with esophagectomy and pancreatectomy, low volume units, high mortality, high volume units, low mortality. So as the number of cases done per year is going up, the mortality is dropping. And this was demonstrated for surgeons and for centers. The biggest complication that we worry about are, of course, perioperatively hemorrhage and postoperatively pancreatic anastomotic leak and fistula formation. And this, I always tend to send my, I leave a drain and the drain fluid is sent for amylase, usually on day 3. And that tells us whether there is an ongoing leak or not. Sometimes just looking at the drain fluid will tell you, but it's worth sending the drain fluid for amylase. And if that is the case, then I will continue to give octreotide. If not, and think about other options like should I stop feeding them? Should I cover them with an antibiotic? Should I increase the dose of octreotide? Those are the things to think about. This is the statistics after resection of pancreatic ductal adenocarcinoma. After resection, 5-year survival is about between 7 and 25%. And if it is unresectable, locally advanced, 6 to 11 months median survival, metastatic disease, 2 to 6 months. However, that is pancreatic ductal adenocarcinoma. Ampullary cancers, cholangiocarcinomas, neuroendocrine tumors, and duodenal cancers all carry better outcomes, as you know. The thing that changed the thinking with regard to adjuvant chemotherapy is the SPAC study, as you know, which was a collaborative study which came out of Europe, and was the first author was Professor John Neoptolemus. Its results were like this: 5-year survival with surgery was 10%. With adjuvant chemoradiation or chemoradiation plus chemo, there was no significant difference compared to just surgery alone. But adjuvant chemotherapy, there was a significant improvement by almost 3-fold improvement in 5-year survival. Now, this was quite bizarre because the chemotherapy they were giving was 5-FU, which had been around for donkey's years and had not been shown to be very beneficial in treating pancreatic cancer. So why it was so beneficial given as adjuvant chemotherapy, no one was really very clear. But it did start us offering new adjuvant chemotherapy, and gradually FOLFIRINOX has come in then Gem Abraxane has come in, and certainly the whole chemotherapy scenario with pancreatic cancer has changed quite dramatically. So there is some hope there, some chink in the armor of the beast. This is how I think the decades of pancreatic surgery have gone. 1940s, it was, hey, we can resect. That's great. So through the 50s and 60s, you saw case reports and some hospitals started doing it. 70s and 80s, we said, oh, there is acceptable morbidity, acceptable mortality. It was only from the 90s that we started seeing surgery getting centralized in the Western world. Beginning of this century, you started seeing adjuvant and neoadjuvant. Then there is focus on quality of life. And finally, now we are thinking about long-term survival and how we can improve long-term survival. What is next for the pancreatic surgeon doing Whipples or pancreatic resections? These are just my thoughts, and I would be very happy for you all to ask questions or state your views on this. I think we have finished. We have come to 6 o'clock, so we have half an hour for the last bit, which is pancreatitis. So, any questions about pancreatic resections for cancer?
Sir, Assalamualaikum, sir.
Sir, I have one question. I am Professor Mohsin, sir. My question is, for pancreatic cancer, you are mainly discussing the pancreatic cancer in the head of the pancreas and periampullary. So, pylorus preserving pancreaticoduodenectomy, sir, actually, we commonly prefer in periampullary malignancy. In case of pancreatic head malignancy, which is resectable, will you prefer pylorus preserving pancreaticoduodenectomy?
So I think depends on the tumor size. If it is involving the periampullary region and it's a small tumor, I will do a pylorus preserving. If it is a large tumor, it is involving the first part of the duodenum, I will do a formal Whipple. So I think clear margin is the prime consideration. If I'm happy that I will get a clear margin and I'm well away from the tumor doing a PPPD, then I will do a PPPD. But if margins will be compromised, then of course I will take the pylorus as well.
Sir, my next question is, sir, will you use pancreatic duct stent commonly or not?
So I routinely use pancreatic duct stent. I will cut an infant feeding tube about size 4, size 5 infant feeding tube to about 10 to 12 centimeters of length. And I will place it across my pancreatico-jejunal anastomosis, about 6 centimeters into the pancreatic duct and 6 centimeters sticking into the jejunal lumen. And I will just leave it there. In many instances, it gradually migrates out and comes down the duct and disappears in the stools. But in a few instances, it remains. And months or years later also, I will see it on a scan, but it doesn't cause any trouble as far as I can see. Very recently, there are reports of self-absorbing stents, which you can use for exactly this kind of situation. They disappear after about 8 weeks. They are called Archimedes stents. That is the brand. And some people in the UK have just started using it. I have never used it so far.
Sir, another question to you, sir. In pancreatic anastomosis with the pancreas jejunum, so occasionally we do also, sir, pancreaticogastroscopy. Sir, do you prefer pancreaticogastroscopy?
So there are some studies that have shown that pancreaticogastrostomy outcomes are better than pancreaticojejunostomy. But I think in most units, it's often a case of surgeon preference, what they do. I've tried doing pancreaticogastrostomy, and I think the important thing is to mobilize the proximal pancreas sufficiently so that you get enough pancreas sticking into the gastric lumen. The stomach is certainly more robust when it comes to holding sutures compared to jejunum. So some surgeons prefer doing a pancreaticogastrostomy if it is a soft pancreas and they think a pancreaticojej is more likely to leak. They do pancreaticogastrostomy in those situations. Some others do pancreaticogastrostomy in every situation. And I'm one of those who, when the first reports of pancreaticogastrostomy came up, I flirted with it for a while, but now I only do pancreaticojejunostomy. I've gone back to doing that as my routine.
Sir, another question to you, sir. Occasionally we see a large SPT in the head of the pancreas. And we do, it is a SPT, solid pseudopapillary tumor of the pancreas in the head. And we are doing a Whipple's procedure in this case. So is it common in your country also?
They are rare tumors, solid pseudopapillary tumors, or PSEN as they are called, papillary solid epithelial neoplasm. They are rare tumors, usually in women, usually in their 30s, 40s. And I think the problem with them is if they are not completely excised, they will locally recur. So I think it is important to get complete margin clearance on those tumors. So if the only way to do that is by doing a Whipple, then so be it.
At that time, occasionally inoculation of the SPT, will you prefer?
No.
Just inoculation of that?
Depends. If you think you're getting a clear, if it is an exophytic tumor and you think you will get a clear margin and you will not compromise the main pancreatic duct, then yes, you can do it. I tend to do enucleations, for example, in
insulinoma,
endocrine tumors, small tumor, neuroendocrine tumors, for example.
Insulinoma like
Insulinomas. But all the papillary, solid papillary neoplasms I've seen have been quite large. So this question has not arisen really.
Thank you, sir.
Thank you very much. I enjoyed that. If there are no other questions from anybody else, yes, sorry.
Can I ask you a question?
Of course.
Okay. So regarding nutrition, post-operative nutrition, when you start the oral feeding in pancreatitis?
So I would normally, as you know, with many hospitals, there are ERAS regimens where they have got a standard protocol for removing the NG tube comes out on day 1, oral fluid start on day 2. By day 3, day 4, patient is eating soft food. I tend not to, in our hospitals, both the NHS and the private ones, we have not made mandatory guidelines for all surgeons to follow, particularly for feeding after pancreaticoduodenectomy. And we often use our discretion as to deciding when the feeding should start. I will usually keep the NG tube for 24 to 48 hours. And if I'm not getting much out of it, I'll remove it. And I will start the patient on sips of water by day 2. Sips of water, in fact, even day 1, just for comfort. But more volumes of clear fluids, water, juice, tea without milk, that sort of thing by 72 hours. By day 4, usually soft diet, if there is no evidence of a pancreatic leak. That's how I tend to go in my practice.
What we do actually in our practice, we use nasojejunal tube. We pass the tube from stomach to the gastroduodenal stomach, the jejunum, wet considerable area, length. And we actually start the feeding in second post-operative day when the boil sign started. So what we can start actually large volume also, 50 ml in the second post-operative day, 100 ml in third post-operative day. So we actually found the better outcome in nutritional point of view.
Absolutely. Especially if your patient is malnourished to start with, which many of them are, then that's a perfectly reasonable way of going at it.
You see, all Bangladeshi people, they actually come in a very poor nutritional state.
Sure.
So they come with 2-3 months suffering from jaundice, and sarcopenia, what we call, losing muscle mass. So
absolutely,
we should start with the
yes,
volumes, and we actually found the good results.
We find that cachexia is not so common in our patients, but if they have got it, then we try and do some preoperative nutrition as well, with high calorie drinks, high protein drinks, etc. And yes, in selected cases, we might also do the same of starting early nasojejunal or nasogastric feeding, but it's not standard protocol for everybody. But your strategy is perfectly reasonable, especially if most of your patients are cachexic to begin with.
So other thing we have seen in our cases, you see, we before during preparing the patient preoperatively, we use the vitamin K. And recently, what we have seen, the vitamin D is also markedly shows deficiency in our patients. So we use vitamin D also in few days before the operation. So whatever, do you have any experience of on it?
I find vitamin D very strange. I can't get my head around the fact that in every part of the world, everybody seems to be deficient in vitamin D. Even in the tropics where there's ample access to sunlight, people are deficient in vitamin D. I don't know what is going on with vitamin D. Certainly, all my patients, if I check their vitamin D in the UK, about 90% will be deficient in vitamin D. But I haven't seen any link between postoperative outcome and vitamin D replenishment in the early or perioperative phase. So I have no experience in that.
Thank you.
Yes.
Can I ask a question? Actually, I am Dr. Shantanu Vishwas. I am a resident in HPD surgery. My question is, when before doing liver resection or before doing pancreatic resection, do you have any scoring system for this prediction? And if you follow any scoring system, what type of scoring system you follow?
So this is it's a very good question, and there is so much variation in this area that it's difficult to give you clear advice. There are several risk stratification systems or scoring systems which are out there, as you know, and many hospitals don't use any. Some hospitals do. We have very recently started using something called Compass, which is giving us a likely. I don't know how relevant it is, but for example, the last patient I did, it came out with there is a 14% chance that this patient will get a complication. There is a 4% chance that this patient will die perioperatively. So you start getting these risk stratification scores. There are several available out there in the market. There is no way of saying at the moment how useful these are, but I think it's worth doing. If nothing else, it allows two things. One is it may allow you to pick out those patients where the risk is coming at 20%, 25% perioperative mortality risk. You might then choose not to proceed in the first instance. You might have, or at least you will have a more informed discussion with the patient about perioperative mortality, and it can go into your consent form as well. And in some ways, it might protect you in the event of a perioperative death. That, look, we did this, we thought about it, we took steps as best as possible to mitigate the risks, and we mentioned it to the patient beforehand. So I think it's worth doing, but what exactly you will do, how you will do it, there is still no clarity on that.
Assalamu alaikum, sir. I have a question, sir. You said that you are routinely using octreotide in your center. Sir, how you use octreotide, in what protocol, when you start and when you stop the
So if you're using it, if you're going to use it, it has to be given before you've made your pancreatic transaction. So we tend to give it on the morning of surgery, and then that way it's on board by the time you have started your operation. Giving it afterwards is not as good. So give it beforehand, either on in the morning of surgery with the pre-medication or at induction. And the dose is 100 to 200 micrograms subcutaneous, 8-hourly. Does that?
How many days, sir, you used it?
If I would give it 5 days, if by day 5 there is no suggestion of a leak, patient has started eating, I'll stop the octreotide. If there is any concern about an ongoing leak, then I will continue with the octreotide. And if there is a persistent leak and we are running into significant problems with a pancreatic or pancreatic fistula, peripancreatic collection, then one can think about giving a depot preparation, because 3 times a day subcutaneous jab is painful. So you can give sandostatin LAR, which is a long-acting depot preparation, and you can give 20 to 30 milligrams of that deep intramuscular, and that lasts for about 4 weeks.
Another question, sir. To what extent, sir, you done lymph node dissection during pancreatic bleeding?
Nodal dissection.
Nodal dissection.
So I will take away all visible lymph nodes. I will try and skeletonize the retroperitoneum where you're lifting it off the aorta and the specimen is coming off the aorta and the cava. I will try and take away all the fat and lymph nodes from there. Similarly at the porta hepatis, but I will not go any further from those. Yeah? Does that make sense?
Thank you, sir.
Okay. I'm thinking it is now 6:20. Zach, do you think we have time to talk about pancreatitis, or is it time to
quickly we can
close
talk
down?
about pancreatitis? No, we can talk about pancreatitis quickly, because I think students might have some questions about pancreatitis. If you just quickly summarize in 10 minutes, that would be probably helpful. And then I'll ask questions.
Okay. Bear with me 1 second. So you all will be familiar with the Atlanta classification, the two phases of pancreatitis, early and late, edematous versus necrotizing, mild, moderate, severe, mild, no organ failure, moderate transient organ failure, severe persistent organ failure. And then there is the terminology is important. You get acute peripancreatic fluid collections, you get acute necrotic collections, and you get walled off necrosis. It's important to use the correct terms rather than peripancreatic fluid, phlegmon, abscess. Those are all understandable, but they complicate matters, and different people might mean different things when they use those terms. So it's useful to stick to the Atlanta classification terminology when you're describing the peripancreatic fluid collections. So I won't go into the etiology of pancreatitis, which you all will know. You know that only a small proportion of acute pancreatitis will go on to develop complications. When it comes to diagnosis, of course, there are clinical presenting features which you all are familiar with. Amylase and lipase are still the most common things, most common diagnostic tests. Okay, so suppose you have got a patient who has got what you think is acute pancreatitis. What will you do next? Your patient is going in via casualty or has just reached the surgical ward. Registrar has made the diagnosis, this is acute pancreatitis, clinical diagnosis. What next? What is the next thing you will do? Trainees?
Score the severity of acute pancreatitis.
Perfect. So what steps do you do? How do you decide the severity of the pancreatitis?
There is several scoring systems, Glasgow scoring. I do the.
Which scoring system do you use in your hospital? This is the one we use in our hospital, the Glasgow criteria. You can use Ranson, you can use Glasgow, there are others as well. So whichever scoring system you're going to use, you do that, and you have to decide how severe the pancreatitis is. And then depending on that, you might, if you think it's mild, the severity score is low, then you're just going to do fluid resuscitation, some pain relief, maybe some oxygen, and monitor the patient. Are the saturations worsening? What's the urine output doing? But if you think it is severe acute pancreatitis, you've scored more than 3 on the Glasgow criteria, and you're concerned. Concerned because BMI may be high, you're seeing some pleural effusion, so on and so forth. So then you put the patient into high dependency, aggressive fluid resuscitation, keep monitoring the O2. If you think there is renal insufficiency developing, notify the renal team, think about hemofiltration. You may then need to put them on inotropic support, watch the clotting, they might start to go into DIC, watch the calcium. Think about early enteral feeding, you may not, and if you're going to do it, it should be nasojejunal. Pain relief, obviously, and in severe cases, you might think about prophylactic antibiotics, or if there is evidence of sepsis, then start them on antibiotics. There's no rule for octreotide or other things. A severe acute attack, imipenem, cefuroxime, or Cipro plus Gent, worth doing. We would normally not put a patient on TPN. What about imaging? If you have you've made a clinical diagnosis thus far, how will you nail the diagnosis? What scan will you do? Any thoughts?
scan with pancreatic protocol?
CT scan with pancreatic protocol, yes. Now, I think the important thing in the clinician's mind at the beginning is, first of all, have I excluded other things? Am I sure this is acute pancreatitis? If you have a doubt that this might be a duodenal perforation, if you think there is something else going on, then a CT on admission is perfectly reasonable. It is only after 72 hours that you start thinking about, hang on, is there pancreatic necrosis? And you're starting to look for pancreatic necrosis. At that point, that's where pancreatic CT comes in. So within 3 to 10, all patients with severe acute pancreatitis who do not resolve should have a CT to look for pancreatic necrosis. And you might see a picture somewhat like this. As you can see here, there is some opacification of the pancreas. There is contrast uptake in parts of the pancreas. But here there is one patch in the neck of the gland where there is no uptake at all. There is no opacification. And then there is peripancreatic fluid stranding, as you can see. So this is quite a typical, you see there is a duodenal edema there. So this is quite a typical picture of severe acute pancreatitis with necrosis. This is another one. Again, there is lots of peripancreatic edema with even a pocket of gas in that. So CT, yes. And ultrasound if you're trying to exclude gallstone pancreatitis, to look for gallstones. This is what I would do. If the other thing is on the scan, if you see an acute fluid collection, you will watch it. But if you see an abscess or a wall of necrosis in a patient who's got signs of sepsis, you will drain that. I'm going to pause there and ask you if there are any questions.
Mr. Satya Bhattacharya, I have got a few questions. You have done a lot of research work. I just wondered if you have carried out any study to assess the tumors for immunohistochemistry to see if any immunotherapy is relevant for carcinoma of the pancreas.
Okay, so we are moving away from pancreatitis back to pancreatic cancer. I personally haven't done any research in this field. Most of our histology specimens anyway come back with some of the immunohistochemical parameters, but immunotherapy for pancreatic cancer is still in a very, very early stage. So it's not standard. And certainly I have not had it used as first line or second line treatment for any of my patients so far. It's only once they have gone into third or fourth line that some patients have been offered that. But please don't ask me what's the name. They all ended in IB, and there are so many IBs around these days, or MABs, that I don't know which one you would give to a patient with pancreatic cancer.
And another question, thank you very much. Another question I'd like to, especially for the postgraduate students, do you give vitamin K therapy regardless of the prothrombin time of the patient? If the prothrombin time is normal, do you still give vitamin K therapy? Do you suggest that they should receive vitamin K therapy?
No, if there is jaundice but normal vitamin K, I would give some vitamin K. But if there is no jaundice and the prothrombin time is normal, then I won't give vitamin K.
No, jaundice, so regardless of the prothrombin time, if the patient is jaundice, you are going to advocate vitamin K therapy prior to surgery.
Yes.
And next question that I had, about the result of morbidity and mortality of reduced morbidity and mortality in high volume center. Is it because of the type of surgery that is done there, or is it because of the very rigid selection criteria? Because low volume center maybe they are very lackadaisical in the in choosing their patient for surgery, but the criteria for operability preoperative assessment in your high volume center is likely to be more than in a low volume center. So do you think it has got anything to contribute towards the better result and worse result in high volume and low volume center respectively?
Professor Majid, that's a very interesting question and a thought-provoking one. So, in an ideal world, all centers will be following roughly the same selection criteria for deciding which patient with pancreatic cancer will have a resection. And most of them go by not tumor size, but presence or absence of vascular involvement, presence or absence of local distant lymphadenopathy, presence or absence of liver metastases. So if there are no liver mets, there are no distant lymph nodes. Regional lymph nodes which will come out in the resection are fine, but no distant lymph nodes, and no suggestion of peritoneal disease, and there is no vascular compromise, then that should be resected. I think the high volume centers might take on the more difficult or more challenging cases a bit more. So someone who's very, say, has got other risk factors, comorbidities, they are the ones that a high volume center might be more confident about taking on rather than a low volume center. But gradually in the UK, surgery in low volume centers has completely stopped. And it is only done in high volume centers which treat at least 2 million plus of population. So the catchment area for each of these high volume centers is a minimum 2 million, usually 2 to 4 million of population. So I don't know if that answers your question.
Thank you very much. Thank you.
Thank you, Satya. I think we have to stop it now here. But of course, I'll come back to you, Satya. Don't leave just now. And Professor Majid, thank you very much for your comments. But before I go for the quiz session, as you know, the students will answer 5 questions. Whoever is scoring highest will get a, I think, iPod from PHA. So students, you can get ready now. The question will come within, say, a few minutes time, and you need to answer everything correctly. The answer should go through the chat box. You can answer through the chat box, and after all these answers is counted, whoever is giving the highest answer, a correct answer, will be awarded with that certificate and also this iPod. So before I go for the quiz sections, can I get some comments from Professor Majid? I'm really surprised that you are still awake. It's 11:30 in Bangladesh time now. Thank you very much, sir, for staying that long time.
Thank you.
So just any comments about this session?
Thank you, Jackie. It was a very wonderful presentation by Mr. Satya Bhattacharya, and all of us, including the students, have benefited from this. And I'm sure, Jackie, you are going to continue these efforts for our postgraduate students and trainees in the future also. I thank you and also Mr. Bhattacharya for his very wonderful presentation covering all aspects of this, almost all, it's not possible to cover a wide topic like this, but it has been covered very well to the benefit of everybody. So I thank you and also Mr. Satyavacharya for his wonderful presentation. Thank you.
Thank you, sir.
Thank you very much. I think it's too many subjects we have just taken. Challenges in liver resection, management of pancreatic cancer, case scenario in pancreatitis, because I've actually given some options. And when I was asking what are the topics we should discuss about, I think almost everybody wanted to have all these 10 topics to talk. We can't. So I had to ultimately chose these topics. But thank you, Bhattacharya, for a brilliant presentation. But before you go, I've got Professor Bidhan Chandra Das. Professor Das, I'll be grateful if you can make some comments about this presentation today.
Okay, thank you very much for inviting me to this prestigious platform. I think our student can learn, and we also can learn many things from this discussion. And I want to thank Dr. Satyajit Bhattacharya for giving his valuable lectures to the audience for us and also the students. And I think not that time is very short, so select next time out, I think 1 or 2 topics will be better, because if you discuss the things elaborately, because so many issues, small and big, recent advances. So I think not 3 or 4, 1 or 2 topics will be better for exploring the things. So I learned many things from you, and thank you very much.
Thank you. Thank you for your kind comments. And please excuse me, I have to leave now, but it's been an absolute pleasure talking to you all. Thank you very much. Thank you. Thanks for inviting me.
Great pleasure to meet you and see you again. Thank you. Now we have got quiz sections now. So before we conclude, I think I've got Professor Mohsin Chaudhary. Thank you, Branson Bhai, for joining in. I mean, of course, you have been doing a tremendous job in Bangladesh as a hepatobiliary surgeon. But how do you like this lecture today? I know it's a very short time. We can't cover everything, but your comments about that.
Thank you, Professor Zakirullah, for giving me opportunity as a panel member in this wonderful scientific sessions. Actually, the hepatobiliary pancreatic surgery department here is a high volume center in relation with liver surgery, pancreatic surgery, even the pancreatitis also. So thanks to Professor Bhattacharya for his excellent, wonderful lecture. For me as well as for my postgraduate students, I learned many things from him. Some practical questions, practical management, and also my respect to my respected teacher, Professor Mojid sir, still waiting, always encouraging us by remaining in this type of session. Also thanks to Kollol for inviting me in this session. Thank you very much. We enjoyed it.
Thank you very much, Professor Mohsin Chaudhary. And Kollol, I mean, he's always helping us in this particular, not only on this platform, in every platform where I need any help, especially get to know the proper person to join in, and he's always there. So Kollol has massive contribution for this particular program today. And he mentioned about Professor Mohsin Chaudhary and Professor Das's contribution as well. So Kollol, your comment about that. You are going to be professor very, and hopefully in future. But what I'm trying to say, from the student's perspective, did you like the sessions, or do you want any change to the sessions in future?
Thank you very much for selecting me as a co-moderator of this prestigious lecture, because the spokesperson or the presenter was such a illustrious career. So I was very much overwhelmed to be a co-moderator in this session. And it was so simple, but so important. he made all the three topics very simple, and he explained everything so nicely that I think the students might possibly enjoy it a lot. And as a student myself, I also enjoyed a lot. I learned many things which were some were known to me, some were unknown. So I think this kind of session will be very much beneficial for the students' sake. But as Professor Bidhan sir said, the session should be comprised of single topic. We can bring him for like 3 or 4 sessions because he's such a resourceful person. But a single session or a single topic should be fixed, and that would be more beneficial for the students so that you can have an elaborate discussion on a single topic. And I also thank all the panelists because I requested them to join and they gracefully joined this session. Professor Mujid sir is always wonderful. He joins every session whenever he asks for. So I thank Professor Mujid sir, Professor Mohsin sir, and Professor Bidhan sir, and at the same time, Ajad sir, for joining as a panelist and enrich the session. Thank you very much.
Thank you very much, Kolol. Unfortunately, Professor Azad was not feeling well, so he had to leave. Anyway, we are going to the quiz sections now. There are 5 questions. Students, please answer correct questions and you'll be scored according to your correct answers. And the first prize will go to the winner who will score the highest mark. So we can start quiz questions now, Thomas. You'll get about 30 seconds per question. And then you have got answers already there. So correct answer will be given later on. So please answer those questions in your chat box. Okay, we can start now. I'm sure everybody can see this one. What are the surgeon's aims in a liver resection? Remove all visible disease safely or safety with clear resection margins, leaving adequate volume of liver tissues, or all of the above. Whichever is correct, you can write down. Okay, second question now. I think there's a marking came up here. Who wrote, sorry, number 2, question number 2. Go back to number 2, sorry. Yeah. Who wrote the New England Journal of Medicine paper in 2002 that gave the correlation between hospital volume and GI cancer resection? Please ignore that red marking. It's probably a mistake. Yes, take it off now, yeah. Now, question number 3 is coming up now. Okay, we can go to number 3. If an otherwise resectable pancreatic head abuts 3/4 of the circumference and 2.5 centimeters of the length of SMV on CT, what will you do? Give neoadjuvant chemotherapy, trial dissection, give neoadjuvant radiotherapy, give chemotherapy with a palliative intent, all of the above. Now we'll go to question number 4. Question number 4 is, give the modified Glasgow criteria for assessing severity of acute pancreatitis. Please write down the answer, especially what it should be the age or PO2 albumin, calcium, white cell count, LDH, glucose, and urea. So there are 8 points. If you correctly write it down, you'll get 8. Your score will be 8. I'll give a little bit of time here because it might take a little bit of time to write down. What should be the minimum age? What should be the minimum OPO2? Albumin level, calcium, white cell count, LDH, glucose, and urea. And the last question now is state the contraindications to surgery that may be seen on CT for pancreatic cancer. Remove all visible disease safely or safety with clear resection margin, leaving adequate volume of liver tissues, or all of the above. So that's the end of our quiz session. It will take a couple of minutes to get the results. So we can go back to our discussion again. Now we have got Shakil Farid, probably. Can you talk to us, Shakil? Are you still driving, Shakil?
Zakir bhai, no, thank you. I just reached home literally now. So no, I'd like to thank the speaker and all the panelists for their valuable time. It's been a really good interactive session, and I'm sure the participants will find it worthwhile. And a huge thanks to Professor Mujid sir for staying so late. And it's a testament to sir's dedication towards educating the next generation. And we hope that we will be able to organize a general surgical conference next year in Bangladesh, and have some faculty from over England to Bangladesh, and it will be very useful for the trainees. So huge thanks to everyone once again for staying back so late.
Yes, that will be very expecting on the 23rd and 24th of February 2024. And of course, Tasbir is here. He is the main man. Of course, everybody's contribution should be counted as well. But Tasbir is the main man and main idea, main brain to think about this PHA. And I'll be really grateful if Tasbir can have some comments about this session today. Tasbir.
Zakir bhai, thank you so much. I actually, not being a surgeon, and I'm being an intensivist and pulmonary, I listened whole lecture and I learned so much. It was so interactive, so engaging. And I'm really impressed with the participant from Bangladesh. They answer almost 90% question correct and confidently. There's no hesitation in answering questions. So I'm so impressed with my audience, to be honest. I want to thank all the panelists, and I want to thank you and thanks the moderator and Shailu Jakrullah bhai. He's instrumental in the PHA. I don't think so without his blessing, support, and wise, decision, always guiding us. I don't think so we can reach at this level. Today, we just have our 3 years, just past 3 years. So we actually PHA established in July 2020. I just want to say one thing quick, that we have PHA Global Summit that is in February 23rd and 24th. The venue may change. Now you can say it is in the Bangabandhu International Conference Center, but things may change, but we are getting some conflicting, the advice. Is a good idea to do it there or not, because government can cancel anytime, and they said they will do their own conference. So we'll announce very soon, maybe in a week, but the date is fixed, 23rd and 24th. It is a multi-speciality conference. Where under the same roof, you will see general surgery, oncology, pulmonary, critical care, GI, name it, 10 or 12 subspecialty. We'll run at least 3 or 4 session parallel, and it's a 2 days conference in Dhaka. So I wish that everybody will participate, and please keep an eye on our website, planetaryhealthacademia.org, and also our Facebook page. And I really encourage everybody to participate and make this event very successful. I'm pretty sure Jagrullah Bhai will be in touch with all the panelists today, because we are working very closely with the Bangladeshi counterpart. It's not like just from abroad. It's a joint session. It's like speaker from both sides of the world, panelists is from both sides of the world, chair session is from both sides of the world, and it will be a joint venture. So inshallah সবার সাথে দেখা হবে, and I really look forward for this. Thank you, Jagrullah Bhai.
Thank you very much. Thank you, everybody, for coming in. And today's winner is, I'm going to declare the name, is Dr. Asfar. Can you unmute yourself, please? Dr. Asfar. তোমাকে আমি চেহারা দেখি।
Asfar bin.
Asfar, কোথায় তুমি?
Yes, sir.
Can you see? Dr. Asfar. Congratulations. Thank you very much.
হাত তোলো Asfar.
Hi, দেখি। খুব ভালো ট্রেনিং বোঝা যাচ্ছে, অনেকগুলো অ্যান্সারও করছিল। Thank you very much. You'll be informed from PHA. You'll get a text from us and also from chat box. They will inform you and give you your prize. And of course, your name should be in our PHA.
He is doing MS in hepatobiliary surgery, final part here.
Great. I have no doubt that will pass straight away without any problem. Okay.
Please, Asfar, please leave your phone number or address. With at least the phone number, we can be in touch with you in the chat box.
I will.
Thank you. Thank you, everybody, once again. It's quite late in Bangladesh, and thank you for staying with us. And in future, I would like to do a much more greater program, and we want everybody's help.
Thank you, Jagir Bhai. Thank you. Assalamu alaikum.
Thank you.
Lovely to see many people after many years. Mohsin Bhai, Bidhan Bhai, all of them. কথা হবে. Thank you. Okay. Khuda Hafiz.
Bye, dosto Bidhan, Khuda Hafiz.